Our content. So this week is part two of our look at how hospitalization impacts our pediatric patients. So we know healthcare has a variety of different settings, and based on where we work, it changes what our responsibilities are. Overall, we are going to be responsible for creating that positive atmosphere and advocating for our patients, no matter where it is that we work. When we're in acute care facilities, urgent care settings, kind of more of our traditional hospital settings, we're going to be responsible for, the day-to-day care for our patients. If we're in an office, we might be responsible for things like telephone triage that we might not do in a hospital setting. Clinics are going to have weekends and after hours care that we're trying to coordinate. And then if we're in a home health setting, we might be doing more procedural interventions, things like infusions. We might be doing hospice care or group therapies. We know that pediatric patients handle things very differently than adults do. They need extra preparation and um, instruction when it comes to treatments and procedures. So to get our infants to be compliant with us, we need to get our parents involved. They see their parents as that security person, somebody that they have a good bond and relationship with. So if we're going to have to do something scary and potentially painful, we want that security person there. We can also use familiar objects if they have a specific blanket that they like or a teddy bear. And then we're also going to use those comfort measures. So things like soothing, distracting, giving hugs after procedures to help them through the process. For our toddlers, we're going to do the same thing, but they can also understand simple explanations of the procedure. They're going to do really well if we give them one direction at a time. So one simple thing to do and then move on to the next direction. We want to encourage them to express their discomfort. We need to know when something doesn't feel good, when they're having pain. We need to know that. Sometimes they don't necessarily have the words to be able to tell us what they're feeling. So they may need another outlet to express their feelings. So giving them an opportunity to draw may be one of those ways that they can get their feelings out without having to use their words. They also are expressing that autonomy that we learned about. So the more choices we give them, the more control they have over the situation. So it can be as simple as what color Band-Aid do you want? What flavor juice do you want with your medicine? Do you want a popsicle or a juice box? Giving them simple choices like that will go a very long way with them. They also respond really well to distraction. This is where child life comes really in handy. They can help distract a patient during a procedure, and they have all sorts of fun toys and gadgets that they use. This is where if you're starting an IV, something like Buzzy Bee comes really handy. It's just something that you place above that IV site and it vibrates the skin. So they feel the vibration and they don't feel the poke from the IV. So lots of cool things that we can use for distraction. For our school age kids, they want to be hands-on. They're learning about their environment. They're learning about the medical equipment that we're using for them. So as long as it is safe, let them handle the equipment that we're going to use on them. Let them tour the area that they're going to be in. Letting them see and be hands-on with that will really alleviate some of the fear of the unknown. They again need extra encouragement to verbalize any fears that they might have, any misunderstandings. And they are going to respond really well with small rewards. So things like stickers. If you can give them a treat afterwards, that's going to help them to want to follow your directions and be compliant with that procedure. For our adolescents, remember they are very concerned about their body image. So privacy is going to be their number one concern. So we want to make sure that we want to promote that privacy. We also want to involve our adolescents in their treatment, in their care. They need to be able to make decisions, be able to understand what it is that we're doing. Pretty soon, they are going to be responsible for their own care. So they need practice in advocating for themselves while they still have the security of their parents nearby. They're also just now learning how to problem solve. So they're going to need help learning how to cope with all the challenges that are being thrown at them and these different procedures and treatments that we're doing. So we can help them work through coping techniques as well. How a child reacts to being hospitalized depends on lots of different things, how old they are, how much preparation time did they have? Was this an emergency situation where we had zero time to prepare them? Or was this a planned hospitalization where we had time to talk to them and discuss what was going to happen, understand what they're feeling, and prepare them ahead of time? What kind of support do they have? Do they have a strong family unit where they have lots of support people, or are they reliant strictly on hospital personnel for support? And then their overall emotional health will dictate how they respond to hospitalization. We know that that experience causes stress on kids of all ages. We're separating them from their parents. We're taking away everything familiar to them. And then we're doing painful procedures and intrusive procedures. So those three things are extremely stressful on anybody. So how can we help assist the child and the parents in maintaining their normal routine? This is one that you can either type in or shout out, either way. So how do we maintain a normal routine when we're in the hospital? Ask parents how they do it at home. Yep. Keep the same nurses, same staff, PCAs. Ask parents what their normal schedule is. Yeah. Yeah, include them. Ask their opinion. You guys got it. Your parents are going to be your number one resource in pediatrics. They're going to tell you what normal routines are, what normal behavior is, how the child likes it done, what works well with them, what doesn't. So they're going to be your best bet there. So we can include a lot of those normal things from home in the hospital setting. We can plan our care according to that normal routine. One of the other things that we see is separation anxiety. So this occurs in infants starting at 6 months of age and peaks at 10 months of age. We see this more pronounced in our toddlers. They tend to be a lot more vocal about it. And we talked about the 3 stages briefly last week. So it starts with protest, moves into despair, and then we get to denial or detachment. So protest is that initial outburst. They're crying, they're screaming for their parents, they're just inconsolable. To help with that initial stage, those consistent caregivers are really important. They help provide another person that they can have start to build that trusting relationship with outside of their parents. And we know their normal routine, so we're used to it. We're not, and we can follow it a little bit easier than somebody that doesn't necessarily have that relationship with the child. We can also institute short goodbye rituals that helps the child get through this process of, okay, mom's getting ready to leave. I know that we do these 3 things in this order, and then mommy leaves, and then she comes back. It's developing that ritualism that they're looking for, that normal routine. And then once parents leave, we can distract the child, try and get them involved with something else. We don't want parents to sneak out or try and leave when the child is asleep. because that will disrupt that trusting relationship. So we want them to be aware of the fact that their parent is leaving and that they're coming back. So after that initial outburst of protest, we move into despair. And this is once we stop crying, we're going to be sad, withdrawn. We're not going to play with toys. We're not going to want to talk to anybody. We're just going to kind of mope. This is where distraction comes in key. Trying to get them involved. A security item might be helpful. So if they have a teddy bear, blanket, whatever that item may be. And then the last phase is denial or detachment. And this is a coping mechanism that kids institute to deal with the emotional pain of their parents leaving. So they're going to deny the fact that they need their parents. And when their parents return, they are going to completely ignore them. They're going to keep playing with their toys, keep talking to their friends, keep doing their thing, and completely ignore their parents. So we need to help rebuild that relationship. Help parents ask them questions about their day. We can talk about fun things that they get to do when the parents come home. It's really important that we help the child move through each of these stages and that we provide lots of education to parents so that they don't feel guilty about leaving their child. They need to understand that the child's going to move through all 3 phases once they leave, and that this is a normal part of development. So any child of any age can go through all 3 phases of separation anxiety every single time that their parents leave them. We also know that hospitals are really scary places. We do lots of invasive procedures that might hurt. We take you out of your normal routine. We make you wear our clothes. We don't let you get out of bed if you want to. So all these things create fear. They disrupt our trust level. They threaten our self-control and cause the hospitalization to be a really negative experience. So incorporating those familiar rituals and routines and as much normalcy as possible will help to balance out those bad experiences that we can't avoid. A sign of stress is a regression. So this is where we revert back to a previous level of functioning as a result of the stress that we're feeling. So we might normally drink from a sippy cup, and now all of a sudden we're refusing to drink from anything but a bottle. We might be potty trained for over a year or more, and now all of a sudden we're having accidents. We might normally walk, and now we're demanding to be carried. Those are all examples of regression. So going back to a past level of functioning. And like I said, it's a response to stress. So as soon as we remove the child from that stressful environment, then they should go back to normal behavior. They should stop that regressive behavior. We can minimize that behavior by encouraging the child to do that skill that we know that they're capable of. In order to know what they're capable of, we have to know their level of growth and development. So we're going to have to use our assessing skills, ask parents what their normal routines and behaviors are. We don't want to punish regression because it's just the child's inability to have effective coping mechanisms. So we just ignore those regressive behaviors. We praise the appropriate behaviors. So here's our first critical thinking question. We have a mom of a 2-year-old that decides not to visit because it upsets her daughter too much when she leaves. She says it's going to be easier on everybody if she stays away until discharge. How do we respond to that? What do you guys think? Oh, I don't think I let you guys unmute yourselves. Hey, there we go.
There we go.
I was wondering what happened.
I was too. Okay, so how do we respond? Do we want mom to stay away until discharge?
No. Will you encourage her?
Yeah, we need
Yeah,
members.
you encourage her to stay. Yeah.
Yes, absolutely.
I will re-educate her as well how important it is to stay.
Yeah, for like separation, the separation anxiety and stuff like that.
Yes, yes, we definitely need her at the bedside. So she needs some extra education to understand the fact that this is not this initial outburst that happens when she leaves. That's the only part of the experience that she has. So we need her to understand that her daughter doesn't scream the entire time that she's gone. She will stop. There are different stages that she has to go through. So how do we, what should we encourage mom to do other when she does have to leave? Because she might not be able to be there 24/7. What do we want her to do when she leaves?
If she says that she's gonna come back, then make sure she comes back.
Mhm.
Because
Don't
you don't
latch the
wanna,
child.
yeah, right, you wanna keep building that. You don't wanna mess that trust up, that bond of trust.
Mhm.
When she tells the child that she's coming back, making sure that the child can understand, like being specific,
Mhm.
maybe saying, I'll be back as soon as you finish or after you finish eating your lunch.
Yep.
So they'll know when to expect her.
Yep. We have to use time frames that they're used to. So things like lunchtime, nap time. When we're talking about procedures, we can use length of TV shows, things like that, to give them an idea. But we definitely want mom to have those consistent goodbye rituals, and helping her to reestablish that connection once she comes back. Because we most definitely want her there. We don't want her child to feel abandoned because she's been gone for a prolonged time. Okay, next we're going to talk about pain. And according to the American Academy of Pediatrics, pain is whatever the experiencing person says it is, existing whenever the experiencing person says it does. So that means we take you at your word. Whatever you say goes. Whenever you tell me you're in pain, I'm going to believe you. We do have to remember that kids will sometimes not tell us that they're in pain because they're afraid if they tell us, we're going to give them a shot. So we need to remind them that we're not going to give them a shot if they tell us they have an owie, that we can give them medication other ways, but we have to know about it. We also have to use the appropriate scale to measure their pain. We can't ask an infant to give us a number 0 to 10. That's not possible. Our toddlers also could be experiencing anxiety along with their fear or with their pain. So we have to take that into consideration as well. And we know that patients that have pain secrete higher levels of cortisol, have compromised immune systems, and are going to experience more infections and show delayed wound healing, which is why it's so important that we made it a fifth vital sign and why we assess pain so frequently. So when we're looking at different pain scales, the first one we have is for our 0 to 3-year-olds or a child that's nonverbal. So you may have an adolescent patient that has a handicap that makes them nonverbal. They would still get this behavioral observation scale. So this gives us different aspects of the child's behavior or their demeanor that help us to assess pain. So this particular one is the FLAC scale. It looks at our face, our legs, our activity, our cry, and whether or not we're consolable. We also have a neonatal infant pain scale, which is very similar to this, sometimes referred to as the NIPS scale. And we also have the cry scale that we can use, which looks at crying, whether or not we need oxygen, increased vital signs, our expression, and sleepiness. In our school age kids, preschool and school age kids, we can use the FACES scale to assess for pain. Be careful when you're using this scale, especially if you use the ones that are color coded. Sometimes pediatric patients will pick out whatever face they like best, or whichever one has their favorite color. So make sure that what they're telling you is matching what you're observing. But the whole point is you're supposed to pick one of these cartoon faces that matches your pain level. So just use your critical thinking skills when you are using one of these scales. Another one that we can use in our 3 to 8-year-olds is the poker chip scale. So this is where I give you 4 items and you give me back the number of items that correlates with your pain. So if you give me back 1, it means you only have a little bit of pain. But if you give me back all 4, it means you're in the worst pain of your life. So very similar, just different format. In our patients that are 9 and older, we can use the number scale. So a lot of times that's stuck right on with the faces scale, so that they have both to reference. And then the last one is the Oucher scale that we can use in 3 to 12-year-olds. And this is just like our faces scale, but it has culturally specific photos associated with it. So instead of those cartoons, we get a culturally specific photo because we know different cultures express pain very differently. Some people are very animated in their facial expressions. Other people will keep a very straight, flat affect when they're in pain. So this allows the child to relate to a similar expression of pain that they're used to seeing, rather than these cartoons that are very generic. When we're managing pain, we want to start with those non-pharmacologic techniques. We talked about drawing as a way for toddlers and preschoolers, especially, to get their feelings out when they don't have the words. Distraction, imagery, relaxation, deep breathing techniques. We can use cognitive strategies. One of those is thought stopping, where we have a negative thought and we say stop over and over until that negative thought goes away. We can also use massage, is really effective even in our infant population, gives you that positive sensation instead of your pain. And we talked about last week the fact that pediatric bodies handle medication very differently. We have immature organs that don't process things effectively. So our liver and our kidneys specifically are responsible for a lot of metabolism and excretion of medications, which is why we're relying on those weight-based doses to help us figure out how the body's going to respond to that medication. The goal of providing medication for pain relief is to allow our patient to focus on their surroundings rather than only being able to focus on their pain. We also know that if we don't stop pain from happening, then it will take more medication to be able to relieve that pain that they're feeling. So with pediatric patients especially, we find that it is more effective to use a preventative pain plan. So we're going to give them lower dose medication on a schedule around the clock rather than waiting until they're in excruciating pain to give them a high dose of medication. So that low dose on a schedule tends to be more effective. When we're choosing medications, acetaminophen or ibuprofen are going to be our 2 medications of choice for mild to moderate pain. Remember, we don't use aspirin in pediatric patients that have flu-like symptoms because it can cause Rye syndrome. So that's why we only use acetaminophen and ibuprofen. For our surgical pain or severe pain, broken bones, traumas, things like that, we're going to use opioids. Remember that our pediatric patients have not been exposed to opioids a lot, so they're going to have a more severe reaction to receiving this medication for the first time. So it's really important that we have naloxone on hand in case we have an accidental overdose. So sometimes when we're naive of a medication, then our body overreacts to it and we can have an overdose even if we're giving a safe range of medication. For our short surgical procedures or dental procedures, we are going to use fentanyl is going to be our medication of choice. It has a rapid onset, so we're going to get immediate pain relief, and it also has a short duration. So it's not going to hang around for a long time. We're not going to have to keep the patient in recovery for an extended period of time. So it's really great for those short procedures. And then the last one are topical anesthetics, things like Emla cream that we're going to use for skin sutures, IV starts, lumbar punctures. Even our NICU patients can have Emla cream, and it just numbs the top couple layers of skin so that you're not feeling those initial pokes. When we do conscious sedation, this is typically used for a procedure that happens outside of the operating room. We are giving IV medications that help the patient to forget the experience, not remember what we're doing to them, but it still allows them to maintain their airway, respond to commands, be able to move their body. As long as these patients are receiving conscious sedation, they will be on a 1-to-1 nurse-patient ratio until they get back to their sedation level of functioning. So until their vitals are normal, they're able to respond to commands, they're able to communicate with us, maintain their hydration, and have normal, alert, and oriented, they're going to be on that 1-to-1 ratio. We also have language interpreters that are available in any medical setting, and they are there to help improve the communication between parents and healthcare members. We don't want to use family members as translators because information can be lost in translation. We're asking them to translate medical terminology in a way that their family can understand. A lot of times, those words aren't necessarily in their language. So we're putting a lot of responsibility and a lot of stress on the family, and that's just not helpful for anyone. Healthcare delivery sites are required by law to provide these interpreters at no charge to the family. So we want to make sure that we're using our resources, not putting undue stress on the family. We also have to be very aware of our nonverbal interactions. We want to make sure that we're providing culturally sensitive care so that we can help to decrease the anxiety that patients feel when they enter the hospital. So some of the things that we need to look out for: personal space. Everybody has their own imaginary bubble where you do not want anybody inside your bubble. That safe space around you where you feel comfortable. So making sure that you're paying attention to how close you are in proximity to somebody else, and how comfortable they are watching their body language. Also, smiling is typically intended as a friendly gesture, trying to ease tension. Sometimes it can be misconstrued as you're not taking a situation seriously. So we want to make sure that we keep a professional expression so that we're not being misinterpreted. Same thing with eye contact. Some people prefer direct eye contact. Others see it as a sign of disrespect. And then anytime that we are preparing to touch a patient, we need to ask permission first. We need to explain the type of touch that we're doing and make sure that the patient is comfortable with it. Sometimes something as simple as patting somebody on the head can imply that you feel superior to them. Or in some cultures, if you touch a patient on the head, they think that's robbing them of their soul. So always ask permission before you touch a patient. And then understanding their particular focus is going to help you tailor your interventions. Some people are very focused on the immediate here and now. How does this affect me right this very second? Others are going to be very future oriented. What does this look like long term for me? So understanding where their focus is will help you to explain things in a way that really resonates with the patient. So real quickly, if we're providing culturally sensitive care, which one are we doing?
medical interpreters.
We're gonna be using those medical interpreters. Don't rely on the family. How about for this one? Yep, we're gonna follow the cultural practice in regards to eye contact. We're gonna respect those personal boundaries. Stay outside that patient's bubble.
Asking before touching.
Yep, always ask before touching. That goes with everyone. Last one.
Personal expression.
Yep, professional expression so that nothing can be misconstrued. Good job, guys. So not only do we have to worry about how the child responds to hospitalization, but we also have to worry about the parents because they come along with the child too. So we may see parents expressing their stress through anger, crying, maybe some aggressive body language. Not only are they experiencing this current situation and hospitalization with their child, but they may also be projecting bad experiences that they had personally as they were growing up. So if they had a bad experience in the hospital as a child, they may be projecting that bad experience onto their own child, even if everything had been going perfectly. So we have to be very accepting and understanding of everybody and meet them right where they are. One of the things that causes the most issues with hospitalization is poor communication. It causes unnecessary fear. So some of the things that we can do in the event that we've got an out of control situation, we've got an angry parent, we want to restate their expressed feelings and acknowledge their feelings. They are valid feelings. We understand that that's how they feel. We want to ask questions on how we improve the situation and then work together to make a plan moving forward. We can also role model appropriate interventions for parents, making sure that we're including them in the plan of care so that we can give them some of that control back. So not only do we have to meet parents' needs and the child's needs, we've got to meet the needs of everybody involved in the situation. For our kids, when we're explaining new experiences, we need to be as matter of fact as possible. If we give too many details, we might increase their anxiety. We talked about using those simple explanations and making sure we're using something that they can relate to. So when we're talking about time, using things like lunchtime, dinner time, after your nap. If we tell them mom's going to be back at 2, that means absolutely nothing to them. If we tell them, oh, we're just going to be gone for 20 minutes, again, doesn't mean anything to them. They don't understand the concept of time yet. So we've got to use something that they can understand. We know hospitalization is very frustrating for everybody. You might not have your parents at the bedside all the time like you're used to. Your daily schedule is disrupted. And we're also disrupting your normal developmental progression. So we still need to include activities that promote your development. So for our infants, rocking, cuddling, using a mobile, singing songs. For our school age kids, we can utilize the playroom so that they can still work on their motor skills. For adolescents, they're a little trickier. We're going to be working on those social skills with them. So if there's some activities that they can do in the hospital or adolescents that they can interact with and hang out with, that's going to help build those social skills. And that is also why we have very liberal visiting hours in the hospital. We want parents to be there as much as humanly possible. And when they can't be there, we want that consistency in their caregivers so that we have that trusting relationship. We can help balance good and bad experiences, and it gives us a better understanding of their normal routine. So as we're working together to improve our patient experience, we want to encourage early discharge Sometimes that might mean that we have to implement home care. When a patient's stable enough that they don't need 24-hour supervision, we can go ahead and send them home. We might have a nurse come in and give them an IV medication here and there or something of this sort. That way they can be back in that environment where they can thrive without having to be the risk of being in the hospital. We want to try and promote a happy, relaxed environment as much as we can, to kind of balance those good and bad experiences. We absolutely have to be flexible. If you go in with a set plan and you are not going to deviate from that plan, every single thing that you do is going to go wrong, guaranteed. So if you are not flexible in pediatrics, you are going to be miserable. If we have to use roommates, we want to make sure that they're age appropriate, and we'll talk about that more in a little bit. We also encourage parents to be at the bedside as much as possible. They know their child the best. And we want to promote those developmentally appropriate activities. With our adolescents, they need to be involved in their plan of care. Like I said, they are going to be advocating for themselves and responsible for dealing with their medical conditions by themselves here very shortly. They can think and problem solve through some of this information. So we want to make sure that we're directing our education and our teaching to them specifically, allowing them to participate in their care while they still have their parents there for that sense of security. We're going to skip this one. We're almost done, guys. When we're choosing roommates, we want to pair them with somebody of a similar age. So our adolescents, if we pair them with an infant, they're going to be miserable because that baby's going to be crying and irritating to them. So we want to pair them with another adolescent, somebody that they can socialize so they can work on those developmental skills. We also need to pay attention to the location of our rooms. So our adolescents are all about privacy. So probably putting them right outside the nurse's station where everybody's got a full view of their room all day is probably not ideal for them. Also, we want to save those rooms for our infants that are at high risk for falls or needing that close supervision. So we're going to save our rooms right next to the nurse's station for our infants. Our adolescents can go back toward the back of the unit so that they can have some privacy. With our adolescents, we also have to be on the lookout for emancipated minors. So this is anyone under the age of 18 that is no longer under their parents' authority. So they typically have a documentation for this in writing, saying that they're emancipated. The caveat to that is married minors and minors in the military. They're automatically considered emancipated, and they're not necessarily going to have that paperwork with them. Each state law is different regarding the information that can be released about emancipated minors. So make sure that you understand your state's law and practice on what information you can release and who you can release it to. And then when we're talking about discharge, we should be starting our discharge planning on admission. We know that people digest information in small chunks much better than throwing it at them and then kicking them out the door. So giving them discharge teaching all the way through their entire hospitalization is going to be much more effective. Also, anything that we expect them to do at home needs to be provided in writing so that they can reference it if they forget or have questions. And then any procedures we want them to do at home, we need to observe the fact that they can do that procedure safely while they're in the hospital. We also have behavioral problems that happen as a result of being hospitalized. So we have those regressions. We can also have aggressive behavior that happens. They might have nightmares. We need to integrate that child back into the family and get them back into their normal routine as much as possible. Take our focus off the illness and go back to normal behavior. Help rebuild that trusting relationship. And lastly, when we are sending a patient home, we need to wrap up the whole thing in a nice, neat little bow, and that is going to be your discharge note. So when you're charting a discharge, you need to know who took them home, how we verified their identity, how did they leave, what time did they leave, what did the child look like, all their vitals, medication, the discharge instructions that you provided. You want this nice, neat little snapshot of your last encounter with the patient so that we know the condition they were in when they left. And we briefly talked about home care. So sometimes we have to send patients home still needing medical care in the home environment, especially kids with chronic conditions. They're going to have routine home care. So we rely on community agencies and home health nurses to provide this care. We can also do respite care for our primary caregivers, and this gives them an opportunity to take care of whatever they need to do outside of the house without having to worry about their child's safety. And then we need to make sure that the school system is included in the patient's care. They're aware of any new medications the child might be on, any new testing that needs to be done during the school day, any procedures that need to happen. And that is it, my friends. That is the end of our PowerPoint.
Professor Styles, do we get this the PowerPoint presentation, do we get an email to us or?
It will be in your announcements.
Okay,
So as soon as we're done, I will post the PowerPoint, your Kahoot, and the recording, just like Professor Bogart would in the announcements.
okay, so we're Professor Bogart's students. Do we get them as well?
Yeah, it'll be in your course, just like it would be if you were in her class today.
Okay, thank you so much. I appreciate you.
Let's go over.
Professor Stein,
Yes.
the first